So a recent publication looked at the long-term outcomes and the clinical and genomic predictors of those long-term outcomes in CALGB 40601, which was a randomized phase III trial in the neoadjuvant setting of comparing dual anti-HER2 therapy with trastuzumab plus Lapatinib versus single anti-HER2 therapy with Lapatinib added alone when it was added to paclitaxel as the chemotherapy agent. We had previously reported the pathologic complete response data suggesting, a small but not significant increase in pathologic complete response with the addition of the second anti-HER2 agent. What we found in the long-term outcomes is that small. It was about a 10% difference in pathologic complete response actually did translate into improved outcomes in those patients. Moreover, we found a continuation of what we had started to find in our earlier pathologic complete response analysis, namely that we have very good predictors of both pathologic complete response and outcome in HER2-positive breast cancer patients, particularly tumor-based things like intrinsic subtype and microenvironmental things like immune activation. And what we found and has become clear through CALGB 40601 and other studies that we've looked at, that intrinsic subtype, like the HER2-enriched subtype, actually is much, much more sensitive to the drugs that we give preoperatively. So the pathologic complete response rate is extremely high, but they do worse. And the reason they do worse is because in the residual disease patients, they do particularly worse. So if you have a HER2-driven cancer on a molecular basis, which is basically what HER2-enriched is, if it doesn't acquire pCR, those patients do quite poorly. And I think that's something that we can leverage, right, as we get smarter about how to deliver better anti-HER2 treatments. The other thing we found was immune activation is incredibly important. It's important in triple-negative breast cancer. It's important in HER2-positive breast cancer. We had previously found that immune activation conferred a higher likelihood of having pathologic complete response no matter what we gave the patient, regardless of arm. We also found the same was true for outcome. So immune activation is good as a predictor of chemotherapy benefit, for anti-HER2 benefit. We know it's also for immune checkpoint inhibitor benefit in triple negative. So that's really where I think a lot of research in the future is going to center.